Great. Hello, everyone. My name is Nicole Signori, and I am the Health Professions Coordinator at Michigan Tech University. Thank you so much for joining today. Today's lecture, an update on the behavioral health impact of COVID-19 in Michigan, is part of a partnership that we have with Michigan State University College of Human Medicine. And this is sponsored by Pine Rest Christian Mental Health Services, Michigan State University College of Human Medicine, Michigan Tech University, as well as UP Health System Portage. And so I'd like to introduce Dr. Carol Janney, and she will introduce our guest speakers for today.
Pleasure to be here tonight. Today we have a panel of 4 that will be discussing COVID-19 and its effects on behavioral health. Our first panelist is Emily Barrington, and she's an MSU College of Human Medicine medical student here in Grand Rapids, Michigan, who is interested in pursuing psychiatry for her residency. We also have Dr. Yvonne Edwards, who is the lead author on the publication that inspired this talk. She works at Pine Rest Christian Mental Health Services in Grand Rapids and is a clinical psychologist, as well as the Outpatient and Recovery Services Clinical Director. Currently, Dr. Edwards has a key leadership position in implementing zero suicide initiatives as part of a multi-system suicide prevention collaboration in West Michigan. We also have Dr. Heidi Rollins today, who is a board-certified child, adolescent, and adult psychiatrist at Pine Rest. Dr. Rollins is the program director of the Child and Adolescent Psychiatry Fellowship and assistant clinical professor of psychiatry at Michigan State University. And finally, I'm Dr. Carol Janney, and I serve as the research director at Pine Rest. I'm trained as an epidemiologist and biostatistician. Without further ado, let's go over the outline for this talk. We've divided it into 3 sections. First, we'll be talking about the paper we published in June of 2020 regarding behavioral health impact of COVID-19 in Michigan. Part 2 will assess the mental health impact that actually occurred 1 year later. And part 3 will look at going forward, what should we be aware of and concerned about. So I'm going to turn over the podium now to Dr. Barrington to do the part 1.
Thank you. And thank you everyone for joining us. So part 1 of our presentation will cover our efforts at predicting the mental health impact of COVID-19 in Michigan early on in the pandemic and the recommended response published by Pine Rest. So going back a slide, Preparing Michigan for the Behavioral Health Impact of COVID-19 was the title of a 29-page research report published by Pine Rest Mental Health Services in June 2020. This report looked at risk factors for mental illness, substance use, and suicide, and the predicted impact of COVID-19 on those risk factors. This report used mental health outcomes data from prior disasters, and specifically the 2003 SARS epidemic. And using this information, researchers modeled the anticipated outcomes of the 2020 COVID pandemic. This report also identified groups who could be more vulnerable to the mental health impacts of COVID and evaluated the capacity and challenges of our existing mental health infrastructure in early 2020 to respond to these challenges. Finally, this report created actionable recommendations for responding to the impending mental health needs of Michigan, which were published and promoted. So one main feature of this report was evaluating suicide risk factors and the new or worsening stressors brought on by the COVID pandemic. This past year, Americans have reported increased feelings of loneliness and isolation. Widespread canceling of social gatherings, transition to remote work and school, and mandated quarantine have brought out feelings of isolation and really exacerbated this existing problems. Another impact of these rapid changes in social, economic, and cohabitation have increased relationship stress. Families have reported frustration and conflict from being stuck at home together. And in the beginning of of 2020, divorce inquiries actually doubled. Another impact that we evaluated was loss of housing. This has been a secondary impact of economic depression brought on by COVID. And here in Kent County, we actually saw rates of housing insecurity double during the first 6 months of this pandemic. Some of the other risk factors evaluated will be discussed in further detail. For example, access to guns. This is a known risk factor for attempted and completed suicide. And in 2020 actually showed a record increase in annual gun background checks and sales per FBI data. Looking at this graph, we see a modest increase in gun sales in the past decade compared to the 2000s, and then an abrupt increase of over 50% in the past year alone. Guns are a common source for lethal means of suicide, and more gun sales has historically been associated with increased rates of suicide. Another important factor that was evaluated was unemployment. It's impossible to discuss COVID in Michigan without mentioning unemployment. Prior to the COVID-19 pandemic, the 2019 unemployment rate sat at about 4%. Looking at this graph, we see a timeline from January 2020 to January 2021 and rates of unemployment claims. The greatest spike that we see, and Michigan is our blue line on this graph, the greatest spike was brought on by the implementation of the stay-at-home order on March 24th, which closed non-essential businesses and required non-essential workers to work remotely, be furloughed, or laid off. This led to the peak unemployment in Michigan at around 20% last spring. While many jobs have come back over the past year and the unemployment rate dropped to 8% in December 2020, we are still not back to normal. These statistics are particularly salient because correlational research has actually shown that a 1% increase in unemployment can correspond to a 1.3% increase in community suicide rates, and this was one factor used for our predictions. Some health-specific suicide risk factors that were evaluated included physical health problems, lack of access to primary care providers, increased substance use, and insomnia. Well-documented increases in substance use during the first few months of the pandemic led to further investigation into this topic. Last spring, about a 13% increase in substance use was reported, and as of December 2020, 60% of adults increased their alcohol consumption during the COVID pandemic, citing reasons such as stress, boredom, and the increased availability of alcohol. For folks with chronic alcohol use disorders, COVID has created barriers to attending alcohol rehab, sobriety programs, and peer accountability groups. Anecdotally, I had a rotation on Pine Rest's addiction medicine service this year, and many clients there expressed frustration with not being able to attend in-person AA. They talked about how virtual meetings didn't provide the same level of accountability. There were issues with participants talking over each other in Zoom, which I think most of us have become familiar with this past year. And the transition to virtual technology often creates difficulties in access and utilizing these technologies. In addition to alcohol use, national overdose trends also showed an increase during the beginning of this pandemic. As you see from this data from the Overdose Detection Mapping Program, our red bars represent reported suspected overdoses in January and February of 2020. And then transitioning to the yellow bars, this is reported overdoses going into March, April, and May of 2020. And as you can see, there's about a 17% increase in these reports. These are suspected to be associated with increased depression, economic distress, and isolation associated with this transition. So COVID-somnia is a new term to me. This was officially coined by sleep neurologists. And And this term encompasses a trend towards poor sleep quality and disrupted sleep schedules during the COVID pandemic. Reasons for this include disrupted work and exercise routines, increased anxiety, increased time on electronics. And all of these contribute to worse sleep hygiene and symptoms of fatigue, insomnia, and depression. This infographic we're sharing was shared by a physician and highlights the prevalence of sleep concerns and tips for improving sleep hygiene during these unprecedented times. So wrapping up the rationale behind our concern for increased mental illness, substance use, and specifically suicide during the COVID-19 pandemic, this is an infographic from the CDC summarizing factors associated with increased suicidality. Based on observations and the predicted increase in these risk factors, the PineRest team proceeded to evaluate mental health infrastructure and then propose research-driven interventions to respond to the pandemic.
All right, next slide, please. May not be advancing. While we're getting that settled, we talked a little bit about the infrastructure challenges that we were experiencing already as a state. So we thought it'd be important to highlight that services are already pretty stretched. And we knew COVID would require some critical thinking around ways to improve access and availability to mental health treatment. So we know a significant proportion of individuals in Michigan with a mental illness are already struggling to get treatment. An estimate about 62% of the 1.76 million residents of Michigan with mental illness are getting their treatment. Though that's a good amount, there's still a large percentage there that are not getting covered. So we recognize that with increasing mental illness burden from the pandemic, this will stress the importance of improving access and availability. Behavioral health care provider capacity is already low in some areas. There's a bit of an unequal distribution. The northern half of the Lower Peninsula, for example, has 7 counties that do not have a psychiatrist, psychologist, or substance use treatment facility. So though Michigan is doing well in other areas, we know that distribution isn't as open as it should be. The good news is that now with telepsychiatry, we may actually be more accessible as mental health providers to our patients, which I think is an exciting and important thing to focus on, and it was a bit of likely an unexpected outcome. There are also psychiatrists, we should mention, that don't participate with insurance plans, which can limit care. There's been some interesting looks at why patients aren't getting care. So what are some of the barriers? Sometimes it's affordability. So that's been a cited reason, as well as not knowing where to go and not having enough insurance coverage. We also know that wait times and patients seeking out important care often don't get the access they need. For example, patients in Michigan can wait in emergency rooms for a very long time to get inpatient mental health treatment, and wait times for outpatient psychiatry appointments can also take sometimes months. So we know there's already some room to improve. Next slide, please. All right, so at-risk populations for mental health issues. We know that healthcare providers are kind of a unique population to think about. Certainly healthcare providers are experiencing a significant amount of work-related stressors, taking on the responsibility of caring for their communities. They're likely to experience stricter isolation, and often due to many values that place them in great caring roles, they may be less apt to seek out mental health care for themselves. Surviving caregivers, we know that caregivers who have lost loved ones to COVID have experienced significant struggles with their own mental health and social functioning. Older individuals, unfortunately, are experiencing the most significant physical impacts of the virus, which places them also at higher risk for mental health symptoms that accompany burdens of significant physical distress and disease. Children and teens are experiencing unique challenges. As a child psychiatrist, I'm very privy to this and seeing it in my practice. We know they're experiencing isolation from peers and lack of positive external supports. They are witnessing stress and anxiety and possibly illness of their loved ones. I'll talk a little bit about family stressors on the next slide, but LGBTQ individuals may experience significant isolation from the supportive communities that are typically there and we know connected to improved depression, anxiety, and suicide risk. For youth who do not experience support from their families or parents are particularly at greater risk. Those individuals with pre-existing mental illness, particularly anxiety, depression, relationship conflicts, and sleep problems are likely to have some exacerbation of these symptoms if they're not accessing some of their supports and coping mechanisms. And then individuals with mental illness that are in residential facilities or acute treatment settings are more confined and at risk of exacerbation as well. All right, service delivery changes that occurred early on in the pandemic, as well as many providers canceling or postponing non-life-saving treatments led to some changes in how individuals got care. For example, individuals on the autism spectrum disorder, some of these were important treatments that helped their core symptoms, such as speech therapies, behavior therapies, and occupational therapy. And we know that about 60% of children diagnosed with autism spectrum disorder or a developmental disability reported not even receiving those key therapies in the first several months of the pandemic. And that's certainly concerning. I think the good news is we are seeing some evolvement of services adapting to the pandemic and becoming more available. But at the time we'd written this paper, it was really concerning. All right, next slide, please. As I mentioned briefly in the last slide, there's a lot of unique challenges during the pandemic for families and particularly for kids. And we're noticing that families have experienced major life stressors and changes, including possibly sickness, maybe job loss, working from home, and it's putting a lot of stress on families. So children and teens are sometimes getting less support from their families who are trying to balance the many stressors that it could be placing on them. We also, of course, have seen the quick transition to online education delivery, often in conjunction with those many other stressors, leading to just more conflict at home, unfortunately placing families at higher risk for mental health stress and possibly even abuse or domestic violence. So we should be mindful of that too. And of course, they have less access to stress-reducing experiences that are normally shown to be very positive for families and to help them cope through mental illness, such as connection, time with loved ones, vacations, and entertainment. All right, so we propose some strategies. First off, hopefully this will not seem like a surprise, invest in telehealth. Due to the areas we mentioned that are underserved and in times of social distancing, we knew the focus had to be on telehealth, and supporting telemodes of behavioral health delivery was very imperative. We felt it was important that payers were encouraged to provide reimbursement for providers using telehealth and that this continue beyond the pandemic. We also felt it was important to support the expansion of provider accessibility through grants from private and public sources. An example of this was the Michigan Health Endowment Fund, which awarded $3 million in grants to behavioral health organizations throughout Michigan. We also think just increasing the public's awareness of our services, especially early on in the pandemic, people would sometimes not prioritize getting inpatient mental health treatment, for example, if they didn't know that we were open. So just letting people know our doors are open, we're here, we're trying to be creative in ways we can treat. Our partial hospitalization program for adults did a tele platform. So I think just letting people know that these services were here and available was very important. Next slide, please. Workforce development. So in order to meet the upcoming behavioral health needs, we discussed the need to improve access. Some ideas included looking at retaining existing providers, putting efforts into recruitment and training, particularly in positions where there's significant need or high turnover, like psych tech positions or nursing positions. It was also important to look at health reimbursement. So the state had some allocation of funds to facilities treating patients with Medicaid, for example, and that became very important. We also initiated a zero suicide implementation plan, and Dr. Edwards can certainly speak a lot about that, but just given all the mental health risks and risks for suicide that we knew were occurring, it was important to have a strategy internally to address that and to support individuals who may be at risk for suicide. Right. Next slide.
Thanks, Dr. Rawlings. Next slide. All right. So the strategies discussed were motivated by the sobering conclusion of this report, which was that without intervention, the 2020 suicide rate in Michigan was predicted to increase by 29%. This would translate to about 2,000 lives lost to suicide during the pandemic, in addition to those deaths directly attributable to COVID. Next slide. This report was covered by media outlets as well as being shared with clinicians, health systems, public health officials, and legislators. With this background, we can now turn to the present to review the mental health impact of COVID-19 1 year into a global pandemic. So it's been 1 year since the onset of the COVID pandemic, and it's been a year of tremendous loss and remarkable change. Where we stand now at the end of March 2021, Michigan has had a total of 740,000 cases or people who have been diagnosed with COVID-19. Now, this is likely an underestimate considering how many asymptomatic and undiagnosed cases of COVID have occurred over the past year. Looking at this top graph, which shows the case distribution over the past 12 months, we see that cases were difficult to report early on in the pandemic due to insufficient testing, but we see an undeniable spike over the holiday season. COVID deaths in our second graph are clustered into two major spikes in the late spring and winter. We believe the early spread of COVID, overwhelming of hospitals in highly impacted areas, and lack of effective treatments early in the pandemic likely explain this increased rate relative to documented infections early in the pandemic. So since the start of this pandemic in Michigan, our state has lost 17,000 lives to COVID-19. The mental health impact of this pandemic has been studied by many groups, but the etiology can be more challenging to interpret. So our first source of data is a mass survey by the Kaiser Family Foundation, which showed a nearly 400% increase in self-reported symptoms of depression and anxiety. Looking at rates in the first half of 2019 compared to January 2021, we see self-reported symptoms go from 11% to 41% of adults showing some signs of mental distress. Breaking down this data by demographics, a really interesting outcome was the mental health burden by age. Based on this, we see that young adults were the most commonly affected group, reporting increased symptoms of anxiety and depression. And we actually see a protective effect with increased age. This trend is seemingly counterintuitive since COVID is well known to cause more severe disease in older adults. So why is it that young adults have been most impacted by the mental health impacts? So in our report, we anticipated that young people would struggle with loss of peer supports and social interactions and socioeconomic impacts that typically hit young workers more strongly. Another proposed theory for this impact is that young adults are more likely to have increased social media utilization. And this has been shown to contribute to anxiety from constant exposure to COVID news. In a previous slide on recommendations for decreasing mental distress, limiting news exposure was actually a commonly recommended guideline. And this is one that young people find it very hard to follow. The endless scrolling through bad news definitely takes a toll, and we see that in sleep as well as symptoms of anxiety and depression. It's more likely that older adults didn't experience the same level of information overload simply due to preference of news sources. Another potential explanation for this age-related trend It comes from data showing that people who moved cities during the pandemic felt increased anxiety, depression, and isolation. Young adults typically experience more transition and instability in their lives, and for that reason, they could have been more negatively impacted by the social and cultural changes of the pandemic than older adults with more established support systems. So as Dr. Rawlings discussed, we see the mental health burden of COVID impacting essential workers specifically. We see that burnout, exposure to trauma, and self-isolation to protect loved ones were some of the reasons that essential workers reported higher rates of anxiety, depression, substance use to cope with stress, and more than doubled rates of thoughts of suicide. Another risk factor that was discussed and well documented is association of job loss. As predicted, households who experience job loss were more likely to experience symptoms of anxiety and depression. And it's also worth noting that disparities in occupational privileges were more likely exacerbated by this, as some higher income workers were more likely to have the option of transitioning to remote work, while workers in entry-level positions who were already more vulnerable to job security were more likely to experience job loss as a result of the pandemic. Breaking down the mental health impact by race and ethnicity, you see the data here. Considering the disproportionate impact of COVID-19 pandemic on communities of color, the disproportionate representation of people of color in frontline and essential work, it's not surprising that Black, Latino, and other ethnic minority groups experienced higher rates of anxiety and depression as compared to white counterparts. So another source of data is an American Psychological Association report, Stress in America, which covers a lot of the same topics we've been looking at. Some novel findings they found were that 61% of adults have reported undesired weight changes and experienced significant distress as a result of this. 2 out of 3 adults have reported undesired changes in sleep. So the COVID-somnia has been quite prevalent and quite impactful. And they found that highly impacted populations included, as reported above, essential workers, Black Americans, young adults, and they highlighted another group that we hadn't previously looked at, which is parents. And Dr. Rawlings can speak more to the specific impact on families and parents. So now, a year into the pandemic, we can look back on our report in June of 2020 and evaluate what did we predict and what surprised us. So as we anticipated, there was a massive increase in anxiety, depression, and substance use in Michigan and throughout the country during this pandemic. We anticipated an increased need and utilization of mental health services. And we predicted the importance of telehealth service expansion, although I can't say that we predicted the extent to which that would impact the past year. Some things that we didn't predict were some of the protective factors around suicide that could have come about from this pandemic, as well as the mental health burden of the social unrest and violence that we've seen over the past year.
In terms of suicide rates, they're lower than we expected and are predicted. And never before have I been so thankful to be wrong about something. Locally, suicide rates, there's often a lag between the deaths and when we receive data on that. But we're beginning to get state level and county level data already for last year. And starting with Kent County, which is the county in which Grand Rapids is located, we saw a 30% decrease in suicide deaths this year compared to last. Now, the ability to speak about significance there is going to be limited by it just being one county, which might have some unique factors going on, and the small sample size. But the fact that we saw similar trends here, but at lower rates, so the seasonal effects are still occurring, gives support that that might be a real difference. On this graph, what you see is that the blue line is the 2019 suicide deaths for this county, and the orange line is for the 2020 deaths. And as you can see, as of February, we were on track to have more suicide deaths in 2020 than 2019. But with the onset of the pandemic, you see those lines separating quite a bit. This is consistent with some of the data coming out of Connecticut, where they saw a 20% lower rate of suicide deaths in the first 6 months of the pandemic, and Japan, which saw monthly suicide rates also decrease by 14%. In some of the studies that have looked more specifically at lockdown periods, the rates have actually gone down more during periods of lockdown in the pandemic than other times of the pandemic, which is interesting because those are the times that you often see that we've seen some of those greater increases in symptoms of depression and anxiety and substance use. So why is that not correlating with an increase of loss of life through suicide? Next slide, please. Well, if we dig into the data further, at least locally at the county level, we did see a change in suicide deaths for women over the course of this year. Again, that's comparable to some of what we're seeing in Japan, where suicide rates in the later 6 months for women went up. And so this overall decrease at first and then increased later, evened out to kind of a flat trend for women. But the suicide rates for men have gone down. Next slide. I think one piece that kind of points to what might be going on is when we break it down by age categories. As you can see in this graph, by the much greater gap between the blue line and the orange lines, the greatest difference is in areas of ages in which we saw a greater reduction in that suicide rate was in the young adult age range, age 18 to 29, and in the age range of 40 to 49. Now, those two age groups are intrinsically connected based off the average childbearing age when those adults who are now 18 to 29 were born. Their parents are falling into that 40 to 49 year age range. So as Emily discussed, the impact of some of those economic and occupational factors on those young adults sent many of them home. Others who were being in college, which is a time that we see a lot of risk factors and onset of mental illness generally, were often sent home because their schools were switching to virtual, dorms were closed, as you well know at MSU. And so you now have these young adults back home. It's a well-documented finding that having monitoring by parents is a protective factor for those under age 18. Yet there's nothing to suggest that that protective factor suddenly disappears when they turn 18. So that returning home due to some of those factors during the pandemic may have provided that additional parental monitoring that was protective for those young adults. For their parents, having children under the age of 18 in the house is also a protective factor. So these parents who now had children, young adult children, granted, in their house for a longer period of time, may have experienced both a decrease in loneliness, but also that protective factor of having their adult children in the house. Next slide, please. Further aspects of the protectiveness of having family members in the same house, lockdown, often being there for much more hours, spending much more time together than you normally would see, might be protective, particularly when we look at suicide methods. So the biggest gaps we saw were in the decrease in number of deaths by hanging and drug overdose. That seems noteworthy because hanging deaths require a little more prep, that there's a little more time to intervene than you might see with gun deaths. And in terms of drug overdose, there's often time to intervene. Also, about half of suicide overdose involve opiates. And so if you have increased parental monitoring, there may be less access to some of those more illicit substances that we see in those overdose attempts, combined with more the methods that allow more time for medical intervention and thus having suicides, but not those ending in deaths, are the areas that we do see that decreased rate. So there may be a protective factor that even while the suicide ideation rates were going up during this time, the attempt rate, which we don't necessarily know about, may have gone down, but at least the suicide death rates went down. So that brings us to, why are we seeing that? So why are we seeing that decreased suicidality? In addition to the factors that I mentioned as we went through there may also be a greater sense of hope. It's not uncommon to see a decrease in suicide rates following major catastrophes or things like 9/11, various things that are impacting the whole community. There can be an increased sense of belonging as the community kind of bands together in the face of this larger obstacle hitting everyone. The other piece is some of the unemployment rates by which we use to make our predictions are based off typical recessions. And in a typical recession, even if your company is downsizing, they may be laying off 20% of their workers, and there can still be a lot of stigma related to being one of those workers in that 20%. That's different than how that unemployment happened in Michigan and around the nation with the pandemic. Where based off your field and your connection with the public, entire factories were shut down, that you couldn't really perceive that as being due to your poor work ethic, your work efforts and performance, because it was entirely based off what industry you were on and what kind of role you played at that workplace. So it may have decreased some of the stigma combined with some of the economic relief efforts, may have also decreased the lived experience of some of that financial stress and the stigma around that unemployment. The other possibility is that, as Emily spoke about, there was a lot of efforts across Michigan in terms of mental health, including changing how telehealth is promoted, lots of information and cooperation between various mental health care organizations, and getting the word out that telehealth services are available. And with that, we saw an increase in behavioral health visits. And so some of those public health efforts may have been quite successful, which is why we did not see that anticipated increase in suicide deaths, thankfully. What we can't speak on at this point is how generalizable this was to all of Michigan. Some of the studies coming out of some of those other countries that I've talked about that found an overall decrease in suicide deaths have found an increased rate of suicide deaths for ethnic and racial minority groups, which in Michigan we've seen be more heavily hit by the pandemic in terms of general health care, infection rates, and severe outcomes from the COVID-19 pandemic, particularly early on in the pandemic and in the eastern side of the state. So it's unclear yet how generalizable this is to all of Michigan, and if we'll see the same decrease in suicide rates in the areas that were harder hit by the pandemic and COVID-19 than this county in Western Michigan. Also, the counties have varied in how they've responded to lockdowns and social distancing efforts. For instance, Grand Rapids Public Schools were virtual for a long chunk of the year, which may have increased some of those protective factors of having kids and adults all under the same roof. Next slide. In addition to that, we've talked about the increased family cohabitation, the impact of caring for children, and there may be some other resiliency factors that this increased. So that increased household supervision, parental monitoring, as well as increased awareness of mental health destigmatization may have interacted in bolstering some of these known protective factors that were also impacted by the pandemic in surprisingly positive ways.
Dr. Edwards indicated there are a variety of strategies that were implemented over the past year. There was a huge investment in telehealth, especially for behavioral health services. There was an increased awareness of services that were available in communities statewide as well as nationwide. And there was also support groups, most of them occurring virtually, but as a means to cope with this pandemic. As far as the impact of telehealth transition, the House bill was signed in June of 2020, and it allowed for telehealth and teletherapy to be implemented in outpatient and partial hospitalization settings. This was extremely important. We found that 50% of patients prefer to continue teletherapy post-pandemic, so it has been a positive experience for many people. And also a recent study showed that there was equal efficacy and a greater likelihood of compliance and attendance with telehealth versus in-person visits. Network 180, which provides community health services here in Grand Rapids, Michigan, reported a graph on telehealth services that occurred during this transition. You'll see that prior to February of 2019 and early 2020, there were no phone or telehealth audiovisuals services available. If you look at the right of the graph, March, April, and May, the blue, light blue, and dark blue shades indicate that services were provided by phone or via telehealth. And by May of 2020, 8% of the services were behavioral health services were provided in that manner. So that was an extremely quick adaptation that occurred throughout the state and at other organizations as well.
All right, so just talking a little bit about service changes and how it has impacted children and teens. I talked a little bit about delays in specialty services, particularly for individuals who have autism. But also just noticing the transition to telehealth that we've been talking about. I think for kids and families, this has been really great. It's been amazing to reach kids and teens in a way that typically feels more comfortable for youth, given that our youth have been tech ready and have had it available to them really throughout their lives. So we're seeing amazing access to care as a result of telepsych, especially when it comes to child psychiatry and child therapy, where families sometimes have to travel quite a bit due to the lack of child-specific resources in the area and in the state. Given the improved access, I guess I should talk about some of the barriers. So we're noticing some challenges with telepsych. So even though we're connecting with families in this unique way, there still can be some difficulties getting video to connect. So we may use telephone services. It's still a way of providing service, but I might miss out on some of those important things that we look for, which is family dynamics, seeing a kid in their environment. So we'll take the phone, but having video can sometimes be a bit more ideal, especially when we're looking at more specific diagnoses. Also, we're noticing that some kids with severe anxiety or individuals with developmental disabilities may struggle a bit more in the visual or virtual platform. So that can be actually pretty challenging to engage them, especially younger preschool age children or early elementary age kids, where sitting through an appointment can already be challenging. And now we're adding in the addition of kind of a separate barrier. We've also heard that some teens are missing that in-person connection that can kind of make their providers feel more real, as some of our teens will say, or having the perception of seeing someone in person can make them feel better connected. So I think that's worth thinking about. I will say that we're noticing in the past few months that there's been a rebound in youth seeking treatment for mental health care. This is great. But it also probably speaks to that wave, that fourth wave of need coming in now. We're seeing more youth reach out for outpatient child psychiatry services, inpatient and day program levels of care. We're hypothesizing that maybe families are perhaps better prepared to accept or seek out services, and possibly youth returning to some school programming may be factors for the increase. Next slide, please. So some general trends that have occurred in terms of youth, we've noticed that they've just been spending more time on screens. That's not surprising. So we are as well as adults, and that there's also increased social media use, extensive technology really in all forms in general. And we're also noticing some disruption to daily routines. And as Emily talked about earlier, some sleep problems. And all of this is partnered with less physical activity and emotional eating trends. I think that just sets the stage for some individuals who might have had some mild worries or some difficulties coping that are now transitioning into more of a transitioning more from like a struggling phase into a mental health disorder where their symptoms are impacting them enough that it's getting in the way of their day-to-day functioning. They're needing more care. Substance use concerns are worth thinking about. We talked about them a little bit earlier in terms of how it applies to adults. I think for youth, we're noticing that on one hand, youth are getting more oversight by parents who have changed to working from home, which is great. However, we also know that some adults are using substances more often during the pandemic to cope. And this may mean that kids could have more access or that parents might be a little less attentive to the kids and how they are coping. And we know some teens, particularly ones with pre-existing mental illness, may be more vulnerable to using substances to cope with negative emotions. All right, next slide, please. We're going to be transitioning into part 3, which is looking forward and looking up for one another. And then one more slide, perfect. So the American Rescue Plan Act of 2021, we really wanted to highlight something exciting that's being done, which is Congress has passed this act and signed it into law. So this will allow $1.9 trillion package, which contains significant provisions related to children's mental health. There's going to be an increase, and they're specifically targeting mental health services and substance use disorder programs and services. So this is really exciting, and it should help with what we already identified is a need for more access and more availability of mental health providers.
So what can we expect with some of the changes in 2021? Well, as vaccinations are becoming more widespread and rates of infection then go down, we can expect a return to school and work, which in some ways may be beneficial and are likely going to be beneficial for those adolescents and that burden of anxiety and depression. Concernedly, depending on how much of the reduction in suicide deaths is due to being all on the same roof and having that additional monitoring, that could also increase a certain amount of risk of suicide if some of those protective factors are due to that increased monitoring and close connections in family environments and living situations. We also anticipate a slow and continued economic recovery, which means that there may be some continued risk in terms of mental health and that continued financial burden, especially depending on what happens with COVID relief money as we go forward. In terms of long-term health impacts, that can have further impacts on behavioral health symptoms. Harvard reports that about 50 to 80% of individuals who've been infected with COVID-19 have bothersome symptoms 3 months after becoming infected, and even after they no longer detect the virus in the body. And some of those ongoing health concerns are things that are known to increase symptoms of depression, anxiety, and sometimes even suicide risk in terms of fatigue, body aches, difficulty concentrating, difficulty exercising, headaches, and difficulty sleeping, many of which are heavy hitters when we look at suicide risk. So it remains to be seen which of those protective factors that we're seeing are the most impactful and whether those will be maintained as we go forward and return to the new normal or increased time outside the house. We also expect that some of that anxiety, fear, survivor's guilt, depending on how many losses related to COVID somebody has experienced in PTSD, especially for those who've required the more intensive interventions with severe infections, that those are going to continue to impact mental health symptoms for various individuals. And so with that, we need to continue to remain vocal, supportive, and accessible in terms of mental health. So continue teletherapy options, continue to put the word out and continuing to connect people to treatment and screen, especially those experiencing those ongoing symptoms. Next slide, please. There may also be increased social anxiety that for many individuals, especially those who have remained in social isolation and quarantine situations and social distancing for a longer time, there can be some anxiety about returning to the levels of in-person connectivity that somebody was engaged in prior to the pandemic. For those who've had social anxiety or some fears prior to the pandemic, that year of decreased exposure to those sources of fears can actually increase the symptoms as we return to the increased social contact or more social contact. It also remains to be seen what the impact of new COVID-19 variants might be. These appear to be more infectious, so how that will impact some of these ongoing stressors remains unseen. And the uncertainty about safety guidelines, which we expect to change and fluctuate more as we go into this mix of having vaccinated individuals and not vaccinated individuals, and remaining to be unseen contagion related to those COVID-19 variants, can also be a significant source of stress as individuals assess what is possible. Next slide. This is a graph that was developed by the Joint Commission, which accredits most hospitals in the United States. And many of these of the three waves of morbidity and mortality caused by the pandemic. So this purple line is the first wave, deaths directly caused by COVID-19. We have seen that, we've seen a couple waves of that. The second wave is those deaths that are due to urgent but non-COVID conditions that were restricted in getting that urgent care because of some of the impacts of COVID-19. That too is something that Michigan saw, especially early in the pandemic, where we saw a rise in heart attacks and strokes and other urgent conditions due to individuals avoiding hospitals, not being able to access medical care, etc. The blue wave there is the third wave. The pandemic has interrupted healthcare delivery for a variety of conditions over the last year. And that decreased intervention around chronic conditions has likely resulted in an increased burden of those conditions, our progression of them, our worsening of them. And so we need to be mindful of what impact that will have, which may result in increased deaths due to those conditions not being able to be treated well, or at least increased burden of illness from some of those. And then, as we've been talking about, that red line is the fourth wave. The mental health impacts of this rather difficult year is expected to continue for some time. Following the SARS pandemic in 2003, for instance, countries saw ongoing increases in suicide deaths for several years after the SARS epidemic. If we see a similar thing with COVID-19, we should be prepared and anticipate that those mental health impacts may last significantly past the initial recovery from the infection and the transmission of COVID. Slide, please. Which turns us to what we can do to stay healthy and to get individuals the services they need. And the Stay Well campaign is one way in which our state has acted and has resources available to get people the treatments and interventions they need. This includes virtual support groups, helplines, mental health webinars, behavioral health guides, and video guides. I think the other piece that we can do is continue to check in with our family and friends, those we work with, our neighbors, and check in with how they're doing emotionally as well. Encourage them and let them know that there is teletherapy available through various organizations, and get them connected to those needed treatments.
Just partnering off Dr. Edwards' important messages, other ways to promote health and coping. I'm going to talk about from a family framework, but of course we could apply this all as individuals to our own lives as well. So focusing on routine, consistency in our daily schedules, especially around sleep and physical activity. It's also important to institute for most people some screen-free times. We are so enmeshed in our technology and screens that getting some time away from that will actually be very beneficial and likely important for our mental health. And identify identify activities that can be done to replace this time. I was especially thinking this will be true for youth and young adults as well. Increasing and emphasizing connection and community. We're seeing individuals get very creative in how they do this now with some of the virtual platforms. So it's a little bit of talking on both ends, saying avoid technology, have technology-free time, but then also use it when you need it to connect with others and find your supports. We're encouraging people to stay as optimistic as they can. We know that parents are very anxious and nervous, as we all are as adults, but modeling how we identify our emotions and cope with them and share that with loved ones, particularly kids and teens who look to adults to kind of understand how they should be regulating their own emotions is really important. And then, of course, using language that works for kids and teens. If you are a parent or you're working with families who need that guidance, making sure that we can talk about the pandemic in ways that are accessible and that they can understand, and then also the emotional responses in a way that works for the kid. All right, next slide, please. All right, so do I need help? We think it's really important to kind of have a framework for when you decide to tap into all these awesome resources that we're saying exist, particularly here at Pine Rest. So do I have mild? So you need to kind of go through a self-check. Do I have mild symptoms that have lasted less for 2 weeks? It's important to note that with any stressor, we expect people to have some adjustment time to that. And I think it's important to recognize, you know, how much is it interfering with your day-to-day life? So are you, for example, for mild symptoms, feeling a little down, but still able to do your job, go to work and take care of things at home, maybe some mild trouble sleeping. Perhaps you're still able to focus on the things that help you get through the day and help your family get through the day. In this case, then we'd recommend that you focus on some self-care activities that can help, such as exercising, engaging in social contact, all those important things we talked about, focusing on your sleep and make sure you're getting enough. Now, if you're falling more into that, symptoms have lasted 2 or more, and or they're more severe and really impacting with your day-to-day life. So difficulty sleeping are severe, so much so that you're having troubles being alert and focusing at work or taking care of things at home. Appetite has been significantly impacted. You're struggling to get out of bed perhaps in the morning, difficulties taking care of yourself or taking care of loved ones in the home, difficulties concentrating, losing interest in things that you had pleasurable. These are all probably good warning signs that you may be experiencing depression and need to get help. So this is where you would first reach out, and we found this resource from the National Institute of Health. All right, next slide. Resources, there are many. We have thought of some national resources that you can go to, the National Alliance on Mental Illness, where there are some local chapters involved that connect people in support groups, and also to local mental health if you need counseling or psychiatry. SAMHSA for Substance Abuse and Mental Health Services Administration. The American Academy of Child and Adolescent Psychiatry has a specific coronavirus resource library. And Pine Rest, of course, we are here. We're here 24 hours a day. You can call our number that's listed here. We do have a contact center where at any time of the day that you call, you can get an important discussion with a licensed social worker and somebody who will be able to talk to you and say, what level of care do you need? Would this look like setting up an outpatient appointment? Do you think you're on the more severe side of things where you need to get seen more immediately? And we also have an urgent care center that has really wide availability to get people in and seen within the same day when they have needs. All right.
And finally, yes, and finally, the primary reference for this talk was the Preparing for Behavioral Health Impact of COVID-19 in Michigan. It can be obtained as a publication as shown on this slide. It is also available through the Pine Rest Christian Mental Health Services website. We would particularly like to thank the co-authors who helped with this project. Are listed on this slide. And we'd also especially like to thank Emily Barrington for preparing the slides for this presentation and pulling it all together so we could speak with you today. She has been instrumental. And at this point, the panelists would like to thank you for your attention, and we will open the floor for questions and answers.
I'd like to jump in quickly. I'm Brian Black, a biology professor at Bay College and an advisor of our health professions students. And I've been assigned the task of moderating the question and answer session here. There are a couple questions in the box if one of you wanted to jump in and engage with those. We'll give you a moment to check that out.
Speak a little bit to the eating disorder question. You asked a very good question. I had briefly mentioned, so if we need it read out loud for those of you who can't see it, do you have data on eating disorders and the impact of food insecurity? And it looks like Dr. Edwards tackled that too. So she mentioned some studies indicate an increase in disordered eating. The NIDA has reported 70% increase in eating disorder related calls and chats. I also wanted to point out that food scarcity, we know the pandemic is driving food insecurity and it's at an all-time high, but also that food insecurity often comes with the time of disruption in food intake or eating patterns because of lack of money or resources. And people with higher levels of food insecurity are likely to have higher rates of eating disorders. And more commonly, we see higher rates of binge eating and higher rates of uncontrolled eating in general, and also food restricting around particular food groups that may be less accessible to them at all times. That could be like limiting carbs or desserts or things that might be seen as unavailable to them at all times.
And there's a second question about gun laws and what we can do to decrease widespread deadly gun access.
I'll start clinically. So from a clinical perspective, the more we can do, there's an excellent training through the Zero Suicide website it's called CALM, it's Counseling on Access to Lethal Means. It provides some great ways about how to talk to individuals about access to guns at the time that they are at risk of suicide. So when the suicide risk factors go up, how do you talk to individuals depending on why there's a lot of culture around gun ownership and those pieces. So without challenging what that means in their life, or that family culture or that individual culture, without having to challenge those identities that are deeply connected to it, and even the sometimes protective impact of activities and hobbies that are related to hunting and such that we see in our state. There's ways to talk to them about how to secure and reduce access to those very lethal means, significantly more lethal than other means, during that time of risk. So any healthcare clinicians or even other individuals who are on the call, I highly endorse that. That's a free resource and can give some great ways about how to talk to individuals about how to protect themselves and their family members by reducing access of that individual to guns by that individual who is at high risk for suicide.
I'd like to jump in then with a question of my own. Much of your data was very consistent with my experience as a college instructor. I've seen just an extraordinary increase in students who share feelings of anxiety, depression. I thought your talk was really encouraging, some of the data that you presented about decreases in suicide rates. But toward the end there, that fourth wave you mentioned really sent a chill down my spine. And I'm curious, what kind of things could I be doing as an instructor for my students in terms of helping them navigate this period?
I think whatever there's an opportunity to talk about, hey, this is really stressful. If you're struggling with this, there is help available. Here are some ways to do that. If you have questions, let me know, or giving the number for the college counseling centers, or even Pine Rest. Some students are not always comfortable going through our other services, depending on where they're located. So I think normalizing that one piece that may have led to that increase in behavioral health visits is because there's a lot of talking about it. I did a number of TV and radio spots where we would sometimes joke about, like, well, who's not struggling? It's a pandemic. This is hard stuff. Doing college virtually, adjusting without having access to the social pieces that often make college fun, but still having, some of the stresses of classes. This is hard stuff. And if the adjustment feels hard, that's probably pretty normal. But also you don't have to wait till you need those treatments to access them, that there's help available. You can do that now. So I think whenever we as a community and even as professors can speak to that and just kind of normalize that's okay to do, that's helpful, I think that's a good step to take. Do any of the other panelists have ideas on how else?
I remember seeing a study that looked at having a flyer available in professors' classroom. Right now that we're virtual, you might think, how could that look? Could that be just like a brief screenshot of what your mental health services there are in the college, just so students see it? Because I remember that flyer association was felt to be associated with a higher increase of utilization for mental health resources on campuses. And so I wonder if virtually just showing that at the end of your discussion for the day and just saying, hey, I care about everyone's well-being and I want them aware of this awesome resource if they weren't.
Yeah.
I think the other thing that should be encouraged is there are amazing resources when you're in an academic community that you've already paid for through your tuition. So take advantage of those opportunities, whether that's counseling or support groups. But I think that's an amazing resource that really can be effective and knows that population well. So could really help with minor or major issues that might be stumbling blocks, but if they seek care or support early, it might be a short rainfall versus a drenching downpour, for lack of a better analogy.
Very good. What was I thinking? The challenges moving forward really sometimes feel overwhelming to my colleagues. And when we get together and talk, the question that is often asked is, what don't we understand about these students? How can we connect with them better? There's usually at least a generation or two in age difference between us and our students at this point in our institution, and it's challenging. Does that bring anything to mind for any of you?
I think that sometimes just normalizing it, that even if there's these gaps that maybe you don't follow the same TikTokers, that those types of things, that inside that this is hard, and that no matter how old you are in this pandemic, there's stress, that this is hard as a professor, this is hard as a student. This is hard stuff, and it's not going to go away overnight. That I'm seeing a comment about, the mental health impact as we resume more pre-pandemic features. And so that, I think just normalizing this is hard. It's hard adjusting into this. It's hard adjusting out of this. I think can be helpful, especially I think there can be this perception of it being easier if you're later in life and things. So just some of that, I think, humanity and sharing that.
I think also we need to be kind to each other and realize we're all fatigued. It's not, we may have different skill sets and we may have different comfort with technology or the resources we're using, but it's been a long haul, and we're not over yet.
That's a really valuable sentiment, I think. I appreciate that very much.
I guess I'd add, as a student living through this pandemic, something I've wished for and really appreciated from my school institution is transparency. Sometimes from the student perspective, you don't see all the things that your administrators are doing to advocate for you. You only see what you wish was happening, and something I think the College of Human Medicine has done a really good job of is communicating with students. These are all the things we're doing to advocate for you getting back in clinic, getting vaccines, staying on track for graduation. So just knowing, there's probably so much you do to advocate for your students, but they may not be aware of it. Just really bringing that to their attention and asking, what more can I do to advocate for you? Would go a really long way. So thank you for asking that.
Hey, thank you. I'd invite any attendees to submit additional questions in the Q&A.
I've seen the one that I started, the response to traumatic events often show this initial positive response followed by a decline with a protracted and slow recovery with passage of time. I think that's likely what we're seeing. There is some data that is as encouraging as the initial decrease in suicide deaths is, and matches, for instance, what Japan saw in the first 6 months of their pandemic, which did onset a little bit before ours. Not that it's separate pandemics, but they were hit by it a little earlier than we were in the States. But in the last 6 months, they've seen an increase in suicide deaths. So some of that banding together as we return to, pre-pandemic life in some ways, that you may have less of that shared identity, which is often what we see after traumatic events. And there can be this sense of, if we're not still under quarantine, as we're able to resume normal behaviors, this belief that we should be over the impacts of this last year. But there will likely be lasting impacts, or at least prolonged. And so kind of normalizing that, letting people know that even if, in 6 months we are in a very different place as far as the pandemic goes, you still lost a year of valid social connection, that you also had these stressors, these strains, that when you've been under chronic stress, as so many of us have for that long of a time, that's going to take a toll. And so, just I think setting expectations that you're not going to get over it in a month of resumed normal behavior. It took a year to get here. That's a year worth of stress and strain, and sometimes building up of symptoms and impaired sleep. So giving ourselves grace and encouraging others to give themselves grace in that process.
Hey, I think that's a great message to wrap things up on here. Thank you. I'd like to thank all of you again for a very enlightening and interesting presentation, really valuable for our community. Also thank MSU College of Human Medicine for organizing this, and hope you all have a great evening.
Thank you so much.
Thank you.